and welcome to Microbial Musings, a mini-series podcast on infection prevention. The Arizona chapter of American Academy of Pediatrics is proud to partner with the American Academy of Pediatrics and the Centers for Disease Control and Prevention's Project First Line to bring you this podcast mini-series. I'm Dr. Helene Felman, general pediatrician, member of the Arizona AAP chapter, one of their Project First Line ambassadors, and a member of the chapter's advocacy committee. I do have a financial disclosure as I'm the principal investigator of an Access-sponsored grant to study an AI tool to help diagnose autism. We hope you enjoy this podcast mini-series. Welcome. I'm very fortunate to be here today with Dr. Scott Olson, one of our newest infectious disease directors for the Arizona chapter of the AAP. Today we're going to be talking about flu. So we wanted to provide you with a flu update and talk briefly just first of all, about the clinical features of flu and treatment options for children. I know we're towards the end of the flu season. However, we are still seeing flu in our community. So I guess first off, what symptoms would cause you to think about the flu over other respiratory illnesses?
Yeah, so the first thing that I always recommend is knowing what is circulating in your community, because particularly in younger children, influenza can look like a lot of the other respiratory viruses that we get concerned about, whether it's RSV or human metapneumovirus. And so the first step is understanding what's really prevalent in the community. And when a child is presenting within sort of the heavy circulation of flu in the community, they're going to present usually with abrupt onset of high fevers, respiratory symptoms, typically upper respiratory tract symptoms such as congestion and discharge, with pretty quick progression into a non-productive cough that can then progress into more respiratory distress. So those are the classic symptoms, but then the other typical symptoms that I think most practitioners are familiar with, such as headaches, myalgias, chills and rigors, and then there's some of the less common presentations, but by far and away, high fevers and respiratory symptoms are going to be the most common presenting symptoms for children.
Yeah. And so I always, when I'm looking at a child with upper respiratory symptoms in clinic, I don't tend to think flu unless I see a truly high fever or hear of a fever that's over 101.0. Is that kind of a good practice to think about that? Or do you ever see flu without that fever?
As is the case in medicine, right, there can always be outliers, but I'd say by far and away, most patients with influenza are going to have fevers accompanying them. If you look at the numbers, about 95% of patients are going to have fevers with their flu illness. So I think it's pretty safe bet in an outpatient setting that if someone presents with respiratory symptoms and fevers, you want to be very suspicious of influenza, but the lack of fevers may indicate some of the other respiratory viruses that certainly are usually circulating around the same time over the winter.
What do you think about our point of care testing for flu? I've been in some practices where it's not been so great, and if we suspect flu, and as you mentioned earlier, the community numbers suggest that flu is likely, to just go ahead and treat and not even test. I don't know, what are your thoughts on?
Yeah, I mean, it really depends on what product you're using or what technology. So we know that the kind of old school rapid assays that we used to use, and frankly are used still just because of cost issues most often in outpatient settings, urgent cares, are antigen based. And we know that those tests have limited sensitivity. And so I don't really like those tests very well. I don't tend to trust them as much. If you have someone presenting in the middle of influenza season with fevers and respiratory symptoms and their rapid test, if it's an antigen assay, it most likely is a false negative, and I would counsel individuals to consider still that is an influenza case and treat appropriately. As PCR technology is becoming more cost-effective, more readily available on a small-term tabletop basis, some practices are starting to incorporate that. And I think that those are very sensitive and very specific, or at least the products that are available right now are. And so those tests I would trust better. But I would say if you're part of a group that is using antigen assays, honestly, I would probably go more off of clinical presentation and what's happening in the community, as opposed to really over-reliance on rapid antigen testing.
Yeah. Cool. Thanks. And then the last question I had prepared was, what is the absolute latest time frame you would consider giving the antivirals for flu, and which ones do you recommend of the antivirals that are out there?
Yeah, I mean, in pediatrics, Tamiflu, obviously that's going to be the workhorse for us in pediatric antiviral therapy for influenza. In older patients, there's some newer products that are available. Baloxavir is a newer one that hasn't really gained traction in pediatrics, and I think it's still only approved in those who are 12 and above. But I'd say Tamiflu is going to be really the workhorse still for the next few years. In terms of when to treat, it's really dependent on the patient that you're seeing. So if it is a high-risk individual, either someone who's presenting with severe symptoms or, again, someone who meets high-risk criteria, so younger than 2 years old, underlying conditions such as chronic pulmonary disease, cardiac disease, hepatic disease, renal disease, metabolic disease like diabetes, those patients who are at high risk at any point in their illness, the recommendation is to start antiviral therapy. So even if it's been 3-4 days, those individuals are probably going to benefit from treatment. All other individuals, on an outpatient basis, there really doesn't seem to be a lot of benefit if you start therapy after 48 hours. And the data that's been looked at is comparing outcomes like duration of symptoms, and there's evidence that you can shorten duration of symptoms by about a day or so. And so in low-risk patients, I usually say you can certainly consider therapy if it's within the first 48 hours, but that should be a conversation with families about their preference with therapy. But certainly high-risk individuals, at any point in their illness, I would recommend using antiviral treatment.
Even with some of the side effects that we see frequently, especially like the nausea, the vomiting, the diarrhea.
Yeah.
Even with that.
Yeah, and that's tricky. About 5% of patients are just not going to tolerate Tamiflu.
Yeah.
And that typically is protracted nausea and vomiting whenever they try to take the medicine. Yeah. And unfortunately, in those circumstances, there's not a lot of other great options. And so in those circumstances, I counsel families just to pursue supportive care and just really watch the patient closely for any signs of progressive disease that may require a more aggressive treatment.
Yeah, great. Okay. Next section of this plan talk is learning about prevention strategies for flu, including vaccinations, and also which types of precautions are recommended when we're in both clinic settings as well as hospital settings. So, yeah, how have this vaccine stacked up this year against our strains of flu? What's been...
Yeah. I mean, the first thing to remember is that the influenza vaccines in general tend not to be as effective as other vaccines that we rely on. Yeah. And that boils down to the fact that every year the influenza virus, as it lives in the world, is changing slightly. And so, globally, there are panels of experts through the World Health Organization that determine which viruses from the prior season are likely going to be closest matched to what will circulate the next season, and then we base our vaccines off that guess. And so as a result, our efficacy in flu vaccines can vary pretty significantly from year to year. And this year it seems to be okay. The most recent data that I could find from the CDC that was published back in February, so the big caveat here is that at the true end of the respiratory season, we'll know a little bit better. But as of now, it looks like in pediatrics, the vaccine efficacy of the flu vaccine is about in kind of the 60 to 70% range right now. And that's for preventing medically attended outpatient visits. That report also looked at the vaccine efficacy to prevent hospitalization. And there they found that it was probably somewhere between 50 to 60% protective of requiring inpatient hospitalization. So, those numbers to me are still pretty good,
Absolutely.
Right? I mean, cutting the risk of hospitalization by over half is a very significant benefit.
It's better than some prior years, if I recall. So this is promising for this year in terms of being able to counsel our patients and families, because we still have the flu vaccine in our clinics, at least I do, and I'm still counseling patients to receive it and get it. So that's helpful information to know. So with that, how do you counsel family and friends about whether or not to vaccinate against flu? I hear many times in my office, I got the flu vaccine and it gave me the flu, or I don't do the flu vaccine, and I don't know. What are your thoughts on that?
Yeah, it's really tricky because there are a lot of misconceptions in the public about the flu vaccine. Yeah. And so common ones you'll hear are, I got the flu from the flu vaccine.
Yep.
Or I had the flu vaccine one year and I still got the flu, so what good is it? And then thankfully, I think the concern has been receding related to flu vaccine and autism. I think we in the pediatric community and the medical community know that there have been very large studies that have shown that there is no association between the flu vaccine, adjuvants, and the development of autism, but that is still a concern out in the community. And so, the first thing that I always talk with people about is, it's important to understand that your patients and your families are going to be coming in with very different understandings of how the flu vaccine works, what its concerns are. And so, the first thing I say is you really kind of have to get an understanding of where that family is. How do they feel about the flu vaccine? Have they done it before? And really nail down, if they do have concerns, what those concerns are, so we can help dispel any issues they have. Yeah. And I think that's important too, because we as providers have a lot of influence over whether or not families are going to pursue vaccines. I think at times we all feel like it's a lost cause and why am I going to keep having this conversation? But studies really do show that we have a very strong impact on whether or not families will pursue vaccination. And so really starting with that mind frame of, I would like them to be vaccinated, and so I'm going to give them whatever information they're going to need to be comfortable with it. Because again, as providers, we should also be respecting patient and family autonomy. That being said, I firmly believe that these vaccines are safe and effective. And so I see my role as helping families come to that understanding as well.
Yeah.
So the first thing I say is, we know it's safe. We know it's effective. In the popular press, you'll hear these reports every now and then of, this vaccine doesn't work very well this year. Yeah. And so I like to go back to the actual numbers and say, this is not like MMR, where you can expect 100%, efficacy or something like that. Not, nothing's 100%, but MMR vaccine is pretty good. Yeah. So the flu vaccine is not quite that. But, if you reframe it as saying, for example, we know it can protect against, it decreases your risk of hospitalization by 50%. Like, those are numbers that families hear, and it's a very real understanding. And so I think helping them understand some of those facts, but really understanding where that family is and helping them work towards acceptance, I think, is what our goals should be. And I understand there's difficulties with that, but it doesn't mean we shouldn't be trying.
Right. Absolutely. Yeah. And I always try to teach residents and medical students that our recommendation is very powerful. And if you give a strong recommendation, oftentimes families listen more. And fortunately, as pediatricians, we're one of the most trusted sources of information out there. And that's not always the case in other medical specialties. So we're really fortunate to have that much clout within this patient population.
Yeah. And specifically to the flu vaccine, one of the analogies, right, because it helps to put things in perspective, a little more concrete terms. I explain to some families that the influenza vaccine is a lot like a seatbelt. That we know that the influenza vaccine some years may not be great at preventing acquisition of influenza, but we know pretty well that the vaccine can really mitigate the severity of that event if it occurs. And so I think, I tell them it's kind of like a seatbelt. It's not going to keep you from getting in an accident, but it's really going to limit how severe the damage is as a result. And some families respond really well to that. Others think I'm treating them like a moron, but
I love that analogy. I'm going to start using that one with some of my patients because it's accurate, right? It's not going to protect you 100%, and it most likely will never be like the MMR vaccine. However, it does help a little bit, especially with those hospitalizations. And
I think it's also really important that pediatric providers continue to focus on encouraging families to vaccinate, because if you look at what's been going on over the last several years, we know that while our rates of immunizations against the flu have always historically been below what we as providers would like, since the beginning of the COVID pandemic in 2019, our rates for all immunizations, including influenza, have dropped. And so we know that with the last influenza season, 2023-24, only about 55% of children were vaccinated against the flu in that season, which, even though it sounds low, is even lower than we had been achieving before the pandemic. And I think that if we're going to get out of this hole and see those numbers rise again, I really do think that we as pediatricians, as family practice providers, as primary care providers, really need to make it a focus when we're seeing these families and not just leave it at, oh, you don't want to vaccinate, okay, but really talk with them about the importance of why we want to encourage them and why it's important for them, their family, and their child.
Great. Lastly, with that question, in the office in the hospital, what precautions are recommended if flu is suspected and what precautions are recommended if flu is diagnosed? So I know in the office, oftentimes we don't know when we see a patient, and so we put on all the precautions in the case that it might be COVID, because there is still some circulating COVID. However, in the hospital, things are a little bit different. So for our hospitalist colleagues, what would be your recommendations?
Yeah, I mean, I think that in the initial phase when you don't quite know what the pathogen is, we're all kind of, I don't want to say lucky, but we're all in a scenario where we are using more stringent precautions because of the concern for COVID still. Mm-hmm. We don't need to be doing airborne and gloves and gown for every single influenza patient, right? Okay. We know that it's a droplet-based transmission. Okay. And so really the recommendation is that if you have someone who you're uncertain if it's influenza, that while they're in either the clinic or in communal spaces in the hospital, before they get into the room, patients should be masked, and then providers, when they're interacting with those patients, should be masked, and because it's droplet, we also include gown and gloves. But really, from a nuts and bolts standpoint in a clinic, really what's a good practice is that if the patient is checking in and it's the middle of respiratory season and they have fever, cough, respiratory symptoms, those patients should be asked to mask pretty much right when they're coming in the door and maintain a mask throughout the visit until they leave, mainly just to make sure we're not transmitting it to other individuals, other children, other potentially high-risk patients that may be in your clinic. People, especially during the pandemic, there was this focus on maybe doing separate waiting areas, waiting rooms for sick visits versus well-child visits. And I don't see a problem with that. I do have to admit that the data that's out there to support that approach is not great. However, it seems completely rational that if you can accommodate that, that may be something that is worth considering. And obviously just for patient satisfaction, if you're coming in with your 6-month-old for a well-child check, you don't want to be in the same waiting room as someone who's hacking up a lung. But really, masking the patient is probably the most important. Then obviously, we all know good hand hygiene is also important. So masks, hand hygiene, those are really the mainstay of prevention of transmission within healthcare environments.
And what about those children under 2 who really aren't going to wear a mask and can't and shouldn't be wearing a mask? Is it? Yeah. I mean, that's kind of a tough call. I know we all kind of got very concerned about that particular patient population because we all know.
Yeah, no, it's a good question for a few reasons. I mean, one, we know that younger children are at higher risk for disease if they were to acquire influenza. I don't know if I have a good answer.
Yeah,
as someone who's lived through 2 of my own 2-year-olds, I admit that I can say one thing, but I had a horrible time trying to get masks on my little kids. I think it's just, you put in a good faith effort, and short of that, I don't know what else you can do. I wish I had a magic bullet to that, but I really don't have a good answer.
Yeah, it's a tough one.
Yeah.
But glad to know that you're also stumped by it. Yeah. So lastly, let's talk a little bit about infection trends of flu within Arizona compared to some of the national trends.
Yeah, so this season, we experienced a fairly early peak in influenza. So if you look at prior seasons, you tend to have peak incidence sometime in the late winter. So February, March timeframe, that tends to be when we see the most circulation of influenza. Understanding that that's just the peak, that the circulation of influenza within a population can occur over a period of several months. And what's tricky too is a lot of times we talk about what's normal, but if you go back and actually look at the circulation within the United States in any given year, there's always going to be little subtle differences. So for example, we see seasons sometimes where there are 2 separate peaks. So you'll have circulation of a influenza A subtype, and then as that starts receding, you'll start to get a secondary spike of influenza B circulation in the community. And so those years you can have a really prolonged season. So, here in Arizona and nationally, we had everything peak in kind of late December, maybe early January in some parts of the country. But I always worry that even though the numbers would indicate that we've had a steady decline since then. You never know if there's going to be an emergence of a new subtype during that season that may either prolong it or you might see a secondary wave. My guess is that we're not going to see that this season, but I think that it's very hard to estimate that. And again, that's why we as providers oftentimes say, well, yeah, we're kind of on the tail end of the respiratory season. We still would recommend, if you haven't been vaccinated, catching up now, right? If you have not been vaccinated, because though there's not a lot of circulation, we are still seeing patients who are being admitted for influenza, and there are some really severe cases. So yes, we're kind of on the tail of our influenza season this year, but there's always a chance we could be surprised.
Absolutely. This weekend when I was rounding, we had one patient that was positive for
Yes.
flu B.
Yep.
So it's still out there.
Yeah.
And with that, that's our 20 minutes. And I think we talked about a lot of great things. Remember to compare that flu vaccine to that seatbelt. I love that. It's going to protect you, but maybe not from everything. And that flu each season tends to be prolonged, and it's still not too late, even April, to get your vaccine. So thank you, Dr. Olson. And until next time.